This is the International Academy for Clinical Hematology, the IACH. Happy New Year from all of us at the IACH. Best wishes for healthy and successful New Year 2025. We're very thrilled to kick off this new year with you guys, and we're very excited for the opportunities ahead. And you will see that today we're launching a new series of webinar, and we're very thrilled to invite you to join us on this enlightening journey through the evolution of hematology. So in this exclusive webinar series, we will explore the transformative discoveries and innovations that continue to impact the diagnosis, treatment, but also the understanding of blood diseases. So each session of this series entitles Pioneers in Hematology. Each session will feature in-depth discussion led by a renowned expert master in the field, showcasing the scientific milestones, some personal stories, but also the lasting legacies of these trailblazers. The aim of this series is to enrich our knowledge and inspire new perspective. So today, we're starting this new year with this first webinar, and the ICH is extremely proud to spotlight Professor Thierry Facon, who is an extraordinary leader and pioneer in the field of hematology. His groundbreaking work and commitment to advancing the care of patients have set him apart as one of the most influential figures in modern hematology, especially when it comes to the treatment of multiple myeloma. And you will hear a lot about this in a few minutes. For those who are not familiar with the career of Professor Facon, he is a professor of hematology and head of the Department of Hematology at the University Hospital of Lille in France. Lille is in the northwest part of France, and he has held this position since the year 2000. He has also just finished his term as the president of the French Society of Hematology and is also an active member of the French National Academy of Medicine. He was also president of the IFM, the famous intergroup francophone du myélome, from 2003 to 2006. And he has also presented at many international meetings some studies that you may remember, which have radically transformed the way we treat multiple myeloma. When it comes to the ICH, we are very proud to let you know that he is also the co-organizer of the very prestigious COMI meeting, Controversies in Multiple Myeloma. He's also a member of the ESH, European School of Hematology board. I'd like also to mention that he is also a honorary professor at the Institute of Hematology and Blood Diseases and at the Chinese Academy of Medical Sciences in Beijing Medical College since 2015. He has received many prestigious awards, including the EBMT Achievement Award in 2017, the Bob Kyle Career Achievement Award in 2020, and more recently, the Waldenstrom Award at the International Myeloma Society meeting held in September 2024 in the beautiful city of Rio de Janeiro in Brazil. He has published hundreds of peer-reviewed papers, including several papers actually in the Lancet and in the New England Journal of Medicine. So, as you will guess, Professor Facon's contributions to the treatment and understanding of multiple myeloma have transformed the landscape of this disease. Through his innovative research, clinical expertise, and leadership in seminal clinical trials, he has played a key role in shaping the treatment algorithm that have significantly improved patient outcome. But beyond all of these scientific achievements, I can tell you that Professor Facon, who is a very dear friend to my heart, is also dedicated to education in hematology, but also mentorship. Several stars today, well-established contributors, were inspired by his work, were trained in his department, and he has always fostered a spirit of innovation and collaboration that continues to propel the field forward. So at the ICH, we would like to celebrate Professor Facon not only as a pioneer, but also as a visionary whose work exemplifies the very essence of our mission: to push the boundaries of knowledge and practice in hematology for the benefit of patients everywhere. So please join me today in honoring the remarkable career of Professor Facon and its enduring impact on the field. Thank you, Thierry, for joining us today. So the concept is to have a 15-20 minutes presentation by the honoree, and then we will have a discussion about a few items. So the floor is yours, Thierry. Welcome.
Thank you. Thank you very much, Mohammed. Thank you very much for this very kind invitation. Thank you to the International Academy for Clinical Hematology, and Happy New Year to everybody. It's definitely a privilege to start this new series of webinars, and I'm not totally sure I deserve this nomination as a pioneer, but at least I was part of the IFM, which is a kind of which is a pioneer in myeloma. So that's a group of people fully dedicated to the care of myeloma patients for many years. And what I will show you in the next few minutes is mostly what we did for the elderly newly diagnosed multiple myeloma patients. So I would like to start with, let's say, my mentors, or people who have been extremely important for me. The two gentlemen shown on the left-hand side are Professor Francis Botters and Professor Jean-Pierre Jouet. They were my predecessors at Lille University Hospital, and they were both great hematologists and very, very good people. They have been very, very helpful, very positive, and the I would probably not have been able to do this presentation today without the help of these two great doctors. Uh, the next mentor is Professor Jean-Luc Caruso. He is very well known in the field of multiple myeloma. He is a great expert. He received the Waldorfstrom Award in 2005, so 20 years ago. At the time the meeting was in Australia. And I did not work with Jean-Luc in Nantes, but he has been, let's say, an external mentor, but very important for many of us, including for you, Mohammed, and for Philippe Moreau, for Hervé Avelloiseau, and myself. And the last mentor I would like to mention is Professor Jean-Louis Michaud, shown on the right-hand side. He was a very important leader in malignant hematology in Belgium for many years. He passed away this year, and it took me for the first time at the National French Academy of Medicine in 2018, and this slide basically showed him during this myeloma session. So he has been also very, very helpful for me for many years and for other IFM colleagues. So these are the pioneers. Uh, you cannot be a pioneer alone, and these are the IFM pioneers. So the French myeloma group. The picture is from 2005, May 2005, so 20 years ago. And so you can recognize some big names in multiple myeloma. Professor Philippe Moreau, who is now the head of the president of the International Myeloma Society, Professor Javier Veloiseau, Professor Jean-Luc Caruso, Professor Régis Bataille, and Claire Mathieu was let's say, the mother of the IFM for many years. Jean-Yves Marie was the IFM statistician, and all other colleagues, very good colleagues from the IFM. And so this was at the beginning a very small group of people. So this was just the board 20 years ago. But on this slide, you can see additional some very important people, including you, Mohammed. You are here. And I would also like to mention Jean-Paul Fermont and Michel Attal. So Michel Attal has been of paramount importance for myeloma in your country for many years. I usually say that he has been the best myeloma trialist I have ever seen. He had a very special sense of the good study with the good timing, and he was just a wonderful trialist and a very good friend as well. So this is a brief summary of the IFM philosophy, I would say, or the IFM roadmap. And I think all these things are important here. So cultivate friendship. Uh, we need academic guidance, and this is something important. From my point of view, it means that the trial designs, for example, must come from academic organizations and must come from doctors taking care of patients. It's likely important to go step by step, and this is what we did in the IFM, uh, both for the younger transplant eligible patients and for the elderly. We designed a lot of simple phase 3 studies, and it's good to be simple, and we did not forget good science as well. So very briefly, uh, 4 papers here. The goal is not to celebrate my own publications, but just to take this opportunity for mentioning some additional good mentors and good colleagues. And so this is my first New England Journal paper for allotransplantation in multiple myeloma. As we all know, the leader in the field was Professor Gösta Gatton from Sweden, and many of us were young hematologists at that time, and this was for me an important paper in 1991. This one on Waldenström is also important. The paper was possibly reviewed by Professor Bob Kyle, and it was published in the JCO in 1993. And thanks to this paper, I became a NASH member in 1994. Uh, I met Professor Kyle for the first time in 1994, and he asked me to apply to the American Society of Hematology based on this paper. And so thank you very much to Bob Kyle, who has been a great hematologist and a great mentor for many people. And finally, I would like to briefly mention my first blood paper here. in the early 90s, I did myeloma cytogenetics with, let's say, conventional cytogenetics and conventional karyotypes. So that was not very easy, and just a way to show that we did progress in multiple myeloma biology as well. This is the figure I published in 1995, showing gains and losses of chromosomes with conventional cytogenetics. And on the right-hand side, you have basically what we have today with genomics and quite sophisticated techniques. And this is a way to measure in a certain extent that we did a lot of progress in the field of multiple myeloma. From a therapeutic standpoint, uh, we started with this, and this is basically what we had in the 80s and from the 60s to the 90s. And this is a paper published in the New England Journal in 1994 showing the survival of multiple myeloma patients. And as you can appreciate, no progress was achieved between the 60s and the early 90s. And the median survival of myeloma patients at that time was approximately 2.5 years. So we started with this, and just to briefly mention some works we did in the transplant eligible patients. So this is the first New England Journal paper from the IFM published in 1996, showing the benefits of autologous stem cell transplantation versus conventional chemotherapy. And this was a very seminal work for many countries, for many doctors, and this was important for many patients. And few years later, so this is 2002, we published with Philippe Bourreau this Malphalan 200 conditioning regimen for autologous stem cell transplantation. So the IFM basically established, at least partly, this conditioning regimen for autologous stem cell transplantation we are still using today. The first study we did in the elderly was called the IFM 9501 study. And as you can see, no progress was done with these various combination regimens using either melphalan or dexamethasone, or the combination of melphalan and dexamethasone. So the control arm was melphalan prednisone. We had melphalan dexamethasone, dexamethasone alone, and dexamethasone in combination with interferon alpha. And this is the survival here, and the median survival was between 30 and 40 months. So this was the situation we had before the reappearance of thalidomide. So the thalidomide story is something just amazing in multiple myeloma. Thalidomide was presented for the first time on December 6, 1998, at the American Society of Hematology meeting in Miami by Bart Barloghi. And this was something tremendously important for multiple myeloma patients. So important, the young people today do not realize exactly uh, how much this new thalidomide story was important. And it was also the first step for additional progress, because as I will show you a little bit later, we moved from thalidomide to lenalidomide, pomalidomide, new IMiDs, new cell mode, etc. So this was the start of a new, very important story in multiple myeloma. So every myeloma doctor has a thalidomide story, and this slide just presents one of my patients treated with thalidomide in 1999. We had, interestingly, we had access quite early to thalidomide in France. So when we came back from ASH 1998, we had a meeting with the French agency, which was called AFSAPS at that time. And we say to regulatory colleagues, we have seen extremely good results with thalidomide. may we have access to this drug? Because the drug was available for other disease. And they finally, the French agency accepted very early in the early 1999 to provide access to patients. And this is a gentleman who had a very refractory multiple myeloma in July 1999. And you can see this is IgA and IgAM component here. And after a few weeks of thalidomide at the dose of 400 milligrams daily, he achieved almost a complete response. So this was just a kind of miracle. And but as I said before, many of us have a story like this. But sometimes you do not need to have a lot of patients to see that a drug is very effective. This was definitely the case for thalidomide. So we were very lucky. I have to say that I have been a trialist and a lucky trialist, and with the very important help of many of my colleagues in the IFM. So the IFM did several thalidomide studies, in fact, and this study here was part of ASCO 2006 plenary session. This was abstract number 1, and the discussion was led by Dr. Ken Anderson. So we had a good time at HASH almost 20 years ago with this combination of melphalan, prednisone, and thalidomide. So this is the original first slide of this ASCO plenary presentation. And at that time, we had a 3-arm study having melphalan prednisone thalidomide versus some kind of adapted autologous stem cell transplantation for the elderly. And this is the survival we presented 20 years ago, showing that this is the melphalan prednisone thalidomide curve is the red one, and the median survival was more than 50 months, and it was significantly better as compared to this reduced intensity autologous stem cell transplantation or melphalan prednisone alone. Interestingly, and I say I would not say it's a funny story, but in fact, this paper was very rapidly rejected from the New England Journal, and in few hours. And so we went to the Lancet, and the Lancet did publish this study, and the study was able to hit the front page of the Lancet at that time. So this was in 2007. At that time, the Lancet said that the use of thalidomide in combination with melphalan and prednisone should be the standard of care or the reference treatment for previously untreated elderly patients with multiple myeloma. After that, just to switch to something a little bit different, we had more and more myeloma meetings after the reappearance of thalidomide. So you have to realize that before thalidomide, at the time we had only alkylating agents. At the time we had only autologous stem cell transplantation. We had in fact few myeloma meetings, and then after thalidomide and after all these new drugs, we had more and more myeloma meetings, and today we have myeloma meetings almost every week, and this is important for patients and colleagues as well. So in 2011, we organized what we call today the International Myeloma Society meeting, or International Myeloma Working Group meeting in Paris. And on this slide, you can recognize Dr. Harousseau, Professor Kai. The meeting was organized by Philippe Moreau, Jean-Paul Fermand, and myself. And this was a good time, and many of us still have in mind this important event, or this very friendly meeting we had in Paris in 2011. What was next? So after thalidomide, and as I said before, the IFM process is to go step by step. So we had melphalan prednisone in combination with thalidomide, and we designed a new study using lenalidomide. And so lenalidomide was after thalidomide, let's say. At that time, we had also this knowledge that the low-dose dexamethasone was better than high-dose dexamethasone. So this was published by Vincent Rajkumar in 2006. And so this combination of lenalidomide and low-dose dexamethasone was considered potentially very effective for patients. And so the IFM designed this study called the first study with this MPT control arm and having two arms with lenalidomide and low-dose dexamethasone. So one was lenalidomide low-dose dexamethasone for 18 cycles. The other arm was lenalidomide and low-dose dexamethasone given continuously. And so the study was in favor of this combination of lenalidomide and low-dose dexamethasone continuously. And importantly, this study was very international. So at the time of the publication of the study, this was the more most international study we had done in the field of multiple myeloma. So we had enrolled 1,600 patients in many countries, including Asia, including China, South Korea, Taiwan, the Asia Pacific area, many countries in Europe and North America. So this was a very international study. That was not so common at that time, and the study was published in the New England Journal in 2014. So the study was part of ASH plenary session in December 2013. So the study was considered to be a kind of paradigm changing study and practice changing study. For the first time, we were able to show that in the elderly, we may avoid the use of low-dose melphalan. And we also were partly responsible for this concept of continuous therapy because the treatment regimen, which was ultimately approved, was lenalidomide and low-dose dexamethasone given continuously. So this concept of continuous therapy versus fixed duration therapy is still a little bit controversial, but we are partly responsible for this concept of continuous therapy in multiple myeloma. Then we, as always, we proceeded step by step. And having this lenalidomide and dexamethasone control arm, we combine the CD38 monoclonal antibody daratumumab to lenalidomide and dexamethasone. So this was the so-called Maya study. So daratumumab, lenalidomide, dexamethasone, or DRD. And this study was very successful as well. So the PFS is shown on the left-hand side, and the median PFS with DRD was approximately 62 months, so a little bit more than 5 years. And the survival, the median survival with DRD has been reached at 90 months, which was, let's say, unprecedented at that time for the elderly. So median survival with DRD is approximately 7.5 years, which is not a bad study result. So this was also published in 2019 in the New England Journal of Medicine. This was part of ASH late-breaking abstract session in December 2018. Then, as always, we combine um, the use of we combine this DRD with bortezomib, or you could say we use VRD as a control arm. So these are the last important phase 3 international studies in multiple myeloma, which have been presented or published recently. The first one was called the IMRO study. So the control arm was VRD, which was a very well-established standard of care for multiple myeloma in the elderly and the younger patients as well. And the investigational arm was the combination of isatuximab with VRD, isatuximab being a CD38 monoclonal antibody. And the IFM had an additional academic IFM study called BENEFIT using isatuximab, lenalidomide, and dexamethasone, which is basically an equivalent of DRD versus isatuximab with a VRD light regimen. And finally, we have another important international study called CEPHEUS, having VRD versus daratumumab in combination with VRD. So the primary endpoints were a little bit different across studies. So it was PFS for IMROS versus MRD negativity for the two other studies. And so this is the most recent step for the frontline treatment of elderly patients with multiple myeloma. And the PFS in the IMROS study is shown here. The median PFS was approximately 54 months for VRD, and the 5-year PFS rate was 45% with VRD, and the median PFS was not reached for the combination of isatuximab and VRD. The 5-year PFS rate was 63% for isatuximab VRD, with a long follow-up, with a long median follow-up of approximately 5 years. So this is a new step forward. This is a new progress for these elderly patients with newly diagnosed multiple myeloma. And we also published this study in the New England Journal in June 2024. And the benefit study was published at the same time by my young colleague, Dr. Xavier Leleu in Nature Medicine. So this was a great achievement for the IFM and for all other important colleagues around the world in the context of the IMRO study. So this is basically the landscape. We got started with methylprednisone. We just added thalidomide. We went through lenalidomide, dexamethasone, through VRD. We established DRD as a standard of care, and finally the last step is to have now isatuximab VRD or daratumumab VRD as new standard of care for the elderly patients with newly diagnosed multiple myeloma. And as you can appreciate on this slide, the median survival was approximately 3 years at the beginning, and it is 7.5 years for DRD here, and it is expected to be something in between 8 years and 10 years with the use of either isatuximab or daratumumab in combination with VRD. We have still important questions, and of course the next step will be either the use of cortisol therapy for the elderly and for the younger patients as well, of course, or the use of bispecific antibodies. And we have now several important ongoing studies investigating the use of bispecific antibodies in the front line. And finally, I would like to highlight a few other issues, and which are not related to new drugs. One important issue is still infection. We still have several myeloma patients who die of infections, and this is also the case with new very effective regimens. And this is something we still have to work on. And finally, this discussion on continuous versus fixed duration therapy remains an important discussion, as well as the role of minimal residual disease in multiple myeloma. So these two important things are shown here. This is something we did a few years ago, trying to establish a model for the risk of severe infection. This was not perfect at all, and I would encourage the new young myeloma doctor to work on this very seriously. And we also had an interest in this concept of frailty, and we and others, we published an IFM frailty score, which is being used by us and by some other colleagues around the world. And finally, this interest in frail patients has been highlighted in several myeloma sessions, including the ASH 2018 educational session uh, at ASH a few years ago. So this is now something important. So this concept of frailty has clinical value, and we still have to work on this frailty concept. Just to combine a publication and a picture, I would say, as mentioned by Mohammed, I had two very good myeloma doctors with me. Dr. Xavier Leleu, shown on the left-hand side, is now the head of the hematology department in Poitiers, and Professor Salomon Magnier is with me in Lille. And these are two very brilliant and great hematologists and great myeloma physicians and great researchers as well, great trialist and good friend. And I was very happy to publish in 2024 this How I Treat paper in blood with with my two young colleagues. And this is the IFM. I started showing you an IFM picture in 2005. So this is an IFM picture in 2024 during the last IMS meeting in Rio. At that time, I received, as said by Mohammed, I received the so-called Waldorf Award. And this is my second myeloma family as well. So this is the COMI team with Mohammed, with Arnon Nagler, and with Marivi Mateos. And we have every year a very nice and very friendly meeting in Paris. And the last session will be next May. And this is something very important for many of us. Uh, I would like to finish with just a couple of slides. This one is likely my first myeloma meeting. And in fact, I am here. It was likely in 1985. It's uh, an opportunity to show you other important doctors. And for example, this is Dr. Brian Dury here, and this is Dr. John Blade here. You have this is Professor Waldenström, and on the left-hand side, this is Professor Bob Kai, this is Professor Balogi, and this is Professor Mario Boccadoro from Italy, and the leader of this group, the very good colleague who organized this meeting in Brussels, in Belgium, in 1985, was Professor Benjamin Van Kamp, and I would like to mention him, and because Benjamin Van Kamp has been a great myeloma doctor as well, and very helpful for me at the very beginning of my career. So I would like to thank him for all he did for me in the past, in the 80s. And finally, I would like to thank my wife. So this was in fact my first slide at the time of my IMS presentation for the Waldenstrom Award in Rio last September. And she, of course, she deserved one part of this award, and she is just wonderful, and she has been very helpful, and I love her for many years. So thank you very much for your attention.
Thank you very much, Professor Facon, for an absolutely inspiring and enlightening session. What a superb journey. Your depths of knowledge and passion for advancing hematology have truly left us in awe. So, as part of the Pioneers in Hematology series by the ICH, I think you have set the bar very high. It's a remarkable standard. And all of us here at the ICH are deeply grateful for the invaluable insights. And it was an honor to learn from you, and thank you for sharing this lovely story. Of course, the concept of this webinar is after your presentation to have a small discussion together. And actually, I have a few questions to you. And to be honest, I was inspired by one of your slides. And I would like to kindly ask you to expand on this slide entitled IFM Roadmap. First of all, in your opinion, and can you please explain to our audience, to all of us, the spirit of friendship and camaraderie that is mandatory and needed in everything we do, and if we really want to advance the field together?
No, that's definitely something extremely important. So we have been from the beginning a relatively at the beginning we were a relatively small group of people, in fact, and there was no. It was very very friendly, no strong competition, and uh, and everyone was just wanted to do a good job for myeloma patients. And for example, when I show you this let's say successful series of clinical studies, I should say that these study designs have been challenged in the good way by many colleagues. So this is not the study. The first study was not the study of Thierry Facon. The first study was the study of the group. And I have no time to talk about that, but this design of MPT versus lenalidomide and dexamethasone continuously or not continuously was not just, it was a discussion. It was sometimes a tough discussion in the good way. Sometimes we were not on the same line. Some studies have been strongly discussed inside the IFM, but it has been always very uh, friendly, and uh, and I think that that's very very important. And the others, I said we need academic guidance also because so colleagues from pharmaceutical companies are just wonderful. So I have a lot of good stories with good colleagues from pharmaceutical companies. And for example, and it is also true that, for example, this thalidomide story, this first study with lenalidomide was done with also with colleagues from pharmaceutical companies. The same is true for the combination of daratumumab and lenalidomide. The same is true for isatuximab, etc. But what I do believe that the original idea, the original concept should come from academic people, because just because they know the patients, and they and so they it's the idea should come from academic people, from IFM, from EMN, from other groups, and then these ideas must be discussed with colleagues from pharmaceutical companies. And uh, and at the end of the day, you have a good chance to get a good study. And it's a teamwork in the good sense. So, and I don't like, for example, just if you imagine that one study should be just designed by a pharma company, I don't agree. I am not happy with that. And and so the academic guidance is something extremely important. It's also seems to me that it's going step by step is something important. So you basically in this frame of large phase 3 studies, which are still the gold standard for drug approvals, you if you show that B is better than A, the next step is to have B as a control arm and to investigate C. And so this this process is not brilliant, it's not clever, but it's just the good way to go. It's it's also important, likely, to do good phase two studies, to take time to look at phase two study results before moving to phase three studies. Otherwise, you could take risk for patients, or you you could do let's say some kind of suboptimal job or suboptimal work. And so uh, I have to say that it has always been the IFM philosophy to go cautiously, step by step, cautiously but rapidly, which means also that at the time you get started with a clinical study, you have to go fast, and it has been the value of the IFM for many years as well, being able to just to get the good idea, the good timing, and to conduct studies in the rapidly with a high quality.
But then, Thierry, this is fantastic. And of course, I think most of us agree with you about the importance of the discussions with different stakeholders because we all share the same goal. But I think you insisted during your talk on something which I believe is becoming more and more difficult to perform, which is the easy trial. Now when I look to the design of some trials, there is like the first step, the second step, then the dose finding, and then you have like two randomization at some point. So, what is the secret, the magic secret, where, as you said, you managed to walk us through in the last 20 years or so, A versus B, then B versus C, then C versus D, and maybe tomorrow D versus E?
The most brilliant studies I have seen in the IFM uh, have been the simple studies. And for example, the study published by Michel Attali in 1996, conventional chemotherapy versus transplant, is just simple, obvious. And when Michel also, I say Michel has been the best trialist I have seen. Then, as you know, as we all know, he did VRD with or without stem cell transplantation. You know, this is a very, today you could say this was an obvious study, but nobody was able to do that before. So, and he said, okay, this is what we have to do. This is the most important question for around 2010. So the idea is just the good idea. The timing is good, and just do it simple. I have to confess that I did some quite complicated studies. I did 3-arm studies. And what I can tell you is that 3-arm studies are a little bit tricky, a little bit complicated. So the MPT study was a 3-arm study. The first study with these 2 arms having lenalidomide and dexamethasone versus MPT was by definition a 3-arm study. And okay, at the end it was successful, but it's always a little bit more confusing. And as you mentioned, if you have one randomization, a second randomization, then things are even more complicated. So I I am not saying that you have some good studies with 2 randomizations anyway, but if you can do it as simple as possible, uh, uh, I think it's likely the best way to go.
So let me ask you a question, and this is coming from our audience actually. So you showed in elderly multiple myeloma management that today the best results, at least in the so-called older patient but relatively fit, the best results are the one uh, achieved with quadruplets. And I think your latest, I would say, nugget was this IMROS study isatuximab plus VRD. So if you have to design the next trial, what's going to be the next one? A simple one. Or
No,
you may have other different ideas, actually. You can throw different ideas.
No, your point is well taken, and your point is correct because it's today it's more difficult to design uh, simple studies for many different reasons. The obvious reason is that we have more and more new drugs. So at the end of the day, you may not have enough patients to put in all these new myeloma studies. And something which is also new in the field of multiple myeloma is that we have several drugs targeting the same target. For example, if you look at BCMA as a target, you have several BCMA bispecific antibodies. You have two BCMA CAR-T approved. So it's this kind of having at the same time uh, similar drugs is much more confusing as compared to what we had in the past. You know, in the past, between thalidomide, lenalidomide, and pomalidomide, you had few years. You had that was not the same time frame. Today, you have teclistamab, elranatamab, cilta-cel, etc. All these BCMA assets at the same time, and so there is something new. Is just the competition with very, very similar drugs or very similar assets. So and then the bad thing is that when you have a competition, you need to go fast, and you should not you should try not to go too fast because if you do that, you may compromise safety. You can not do the right study, and for example, just it's a very general comment, for example, but we are not, we know that BCMA and other bispecific antibodies in multiple myeloma are very effective drugs. But we are not sure about the good schedule. And the schedule, we did not take time to establish a good schedule before moving to good phase 3 studies, etc. And this is likely the consequence of this kind of, let's say, competition between similar drugs which are on the market or which are in clinical studies at the same time. So of course, the the new studies should need a quad control arm, so either DVRD or either VRD, at least for the non-frail patients, and may still have a DRD as a control arm for the more frail patients. Then you could of course, one attractive strategy would be to combine a CD38 and a bispecific, or maybe to combine the lenalidomide, a bispecific, and the CD38. But I have to say that I like the concept of combining a CD38 and a bispecific just because it's not a chemo-free regimen, but it's a PI-free an IMiDs-free regimen, and this is something new. But as you know, we will have soon three specific antibodies, not only bispecific antibodies. So from my question could be my interest, for example, could be I would not uh, skip bispecific antibodies. But things are going so fast in multiple myeloma that you may say that going uh, fast or reasonably fast to three specific antibodies will possibly be a good idea. And you could say that okay, you could do possibly better than bispecific antibody with three specific antibodies. And yeah, so the things are going very, very fast in multiple myeloma, and I agree that it could be a little bit confusing for us, and it could be a little bit confusing for pharma companies as well. But the good news is that it's good for patients anyway.
Thank you, Thierry. And I believe having all of these drugs and all of these options is definitely a good problem to have.
It's a good problem
And
to have.
it will keep us busy for the next few years. So, before concluding this very special webinar, what would be your advice to a young colleague who would like to embark in this field of clinical research, whether in myeloma or outside myeloma? Because I think what you have nicely described in your journey can be applied to someone who is interested in lymphoma and leukemia, in any blood disorder or any cancer in general. So, what would be your advice for success, your recipe for success?
Oh, I think you have to be passionate, you have to be so the young hematologists, they have, as we had in the past, they have a lot of energy. They have a very strong interest in cell therapy. Many young hematologists are very, very enthusiastic about CAR-T strategies, for example, new modalities for immunotherapy. But okay, I think I would go back to this kind of, they should work together. I think that this, what is, I, we are happy, I am happy, and you are happy to see the new IFM, for example, because they are like us. So they have a lot of energy, they have a lot of ideas, and it's very important to work together. That's definitely a teamwork. You will always have, as you said, you have we have new drugs for the next 10 years, and new drugs will appear every year. You get a new myeloma drug candidate, and many new drug candidates, in fact. So I have no specific recommendations except the fact that to always to keep in mind that we are here to take care of patients, to do we have to do our best to cure myeloma at the end, cure lymphoma. I think we are not far off curing multiple myeloma, and it's likely that some patients are very likely cured, in fact, with the new treatment modalities. So I am quite confident for the future, and I think the majority of myeloma patients will be cured in the next few years.
Thank you, Thierry. It can take me actually an hour or so to read all the congratulations messages you have received, but I will read only one, which I think summarize all of them. This is from Professor Vania Hungria in Brazil, our friend Vania, and she wrote, Professor Thierry Facon, thank you very much for your pioneering work, bringing so much inspiration to the entire community. So,
Thank you, Vanya. Thank you.
thank you, Vanya. Thank you all for following the ICH. And on behalf of everyone here at the International Academy for Clinical Hematology, I would like to extend my gratitude to Professor Facon for such an outstanding and inspiring career. As a true pioneer in hematology, Thierry, your contribution to the field continue, I think, to shape the way we understand and treat multiple myeloma. Today's session was not only a testament to your immense expertise, but also, and I think you pronounce this word, to your passion for advancing knowledge and improving patient care. Patients are always at the center of everything we do. So thank you for sharing your insights with us and for being a guiding light in the field of hematology. It has been an absolute privilege to learn from you, Thierry. Wherever you are, you're following the ICH around the globe and across the hematology field.
Yeah.
See you soon and take care.
Thank you very much, Mohammed. Thank you. And Happy New Year to everybody. Bye-bye.